a little bit this evening about the management of pediatric neurogenic bladder. I am very grateful for the opportunity to speak with and meet with everyone. The only thing I would like to say before I get started, I mentioned this to Ashley, I do have bronchitis, so if I cough, I apologize. But this is a topic that is absolutely near and dear to my heart. I work with the Spina Bifida Clinic here at Yale, and they're just such a wonderful group of patients, and I appreciate the opportunity to speak about the management of neurogenic bladder. So the most important goal in most important urologic goal is of course to protect the kidney and the kidney function. We aim to limit urinary tract infections, and then also depending on children's age and their cognitive abilities, certainly to achieve social continence and ultimately independence is very important as well. This is a patient that I take care of here, Michaela, and she at the age of 7 ultimately underwent a bladder augmentation and appendicovesicostomy, as well as a MACE for antegrade enemas. So she's a patient that we follow very closely, and sort of has kind of gone through all of the different sort of treatment options that we have to offer. I think one of the most important things is that, a lot of the urologic symptoms, as well as other problems with neurogenic bladder or with spina bifida, they do not get better as patients age, and in fact, a lot of times become more troublesome. Ambulation becomes increasingly difficult on these patients as they get older. They rely pretty heavily on core and upper body strength to ambulate, and if they get heavier with age, it makes ambulation more difficult. And lung function also tends to deteriorate. So certainly anesthesia becomes a little bit more risky as they get older too. And I think one of the things that I was taught at my fellowship at Emory in Atlanta was that problems not sorted out in childhood become more difficult in adulthood. And so one of the things that we will do when a baby with spina bifida is born, I tend to do this study before they go home from the hospital. These babies tend to have their spine closed in the first 48 hours of life. Once they can be supine, once they can lay on their backs again, we will get a VCUG before they go home. In the first picture here, this is a picture actually of a little bit of an older patient. You can see that they've developed irregular bladder contour. There's a lot of trabeculation there. And this second picture, B, is actually of a newborn. And it's interesting, you can see the catheter, you can see the bladder smooth walled, you can actually see left grade 3 reflux, but you can also see that this baby has bilateral club feet, you can see in the x-rays, and also pretty profound hip flexion, which is not uncommon in these patients. Our protocol, we follow the CDC protocol for initial management of infants with spina bifida. They are started on clean intermittent catheterization every 6 hours. One of the kind of battles, if you will, that we fight pretty often with our neonatal ICU is they will say we don't want to do catheterizations if we're not getting a lot of urine out. But we really try for these kids to be on a protocol every 6 hours. And then certainly if the volumes remain low, we can decrease or increase the frequency depending on what a given infant needs. But it's very important for them to be started on this. And also it gives parents an opportunity to learn intermittent catheterization over the course of a couple weeks while they're still in the hospital. The main issue at birth is whether or not there's detrusor sphincter dyssynergia. So whether or not the sphincter is contracting against the bladder muscle and whether or not the baby can empty at low pressures. If an infant can empty at low pressures, then they don't necessarily have to be catheterized until they're older. But until we know that for sure, we like to do intermittent cath to protect the kidneys. We like to do urodynamics, preferably video urodynamics, so with fluoro. at about 3 months of age, so that we're looking at the detrusor filling pressure. We're looking at whether or not they have that sphincter overactivity, and what their leak point pressures are. And certainly if they have leak point pressures over 40, those are the kids that are at risk for renal damage and the kids that we watch very closely. If they have none of these things, so if they have low filling pressures and low leak point pressures, then we will sometimes discontinue the intermittent catheterization. But certainly if any of those risk factors are prevalent, we continue with the intermittent catheterization with or without anticholinergics, which is certainly the mainstay of treatment for these children. So in general, in older kids, we suggest emptying the bladder every 3 to 4 hours to keep the pressures low and avoid urinary stasis and UTI. This is actually successful in 80 to 90% of patients, but it certainly depends on what situation families have. Some children are not able to catheterize themselves. They either don't have the cognitive ability or the manual dexterity to do it. Some of them are just scared or unwilling and feel like it's going to be painful. And so they're just, as we all know, as healthcare providers, if we recommend something that a family or a patient can't or won't do, we have to sort of modify our plan, because otherwise, if they're not following our recommendations, it won't work. And social situation plays a tremendous role with these kids. If they have strong social support and the family understands and is able to do the catheterization, it means so much for these kids and their ultimate bladder and overall health. The cost of single-use catheters is a major drawback. This has become the norm in the United States for single-use catheters, but it's certainly not the case worldwide. The percentages that I could find in the literature was that 20 to 30% of patients that require intermittent cath will still actually reuse catheters. I think that number is probably getting lower every year. But it's, like I said, it's certainly not the case in many parts of the world. And I have taken care of patients in a lot of different places where they use the same catheters and they clean them, and those patients actually do very, very well from an infection standpoint. How we recommend that catheters be cleaned is just that they're cleaned immediately after use with either hand or dish soap and then allowed to air dry. And like I said, from an infection standpoint, there's actually some research that shows that there's increased infections with repeated catheter use, but there's other studies that show that there's not. So it's a little bit conflicting data. But again, a lot of people reuse catheters, and as long as they're catheterizing and doing well, that's the most important thing. So anticholinergics or antimuscarinics, certainly they're the mainstay to treat detrusor overactivity and to reduce intravesical storage pressures. The predominant muscarinic bladder subtype is M2, which is 2/3, and then M3, which is the remaining third. Antagonism of the M3 receptors results in the bladder muscle relaxing, which allows for lower pressures, lower filling pressures. And oxybutynin or ditropan is the mainstay that we use. It comes in a liquid, and as we're going to see in subsequent slides, not a lot of these medications come in a liquid form. And this is something that we very often start in infancy. So the fact that it's a liquid formulation is incredibly important. It also comes in an intravesical formulation, but that can be much more difficult for families. And it can be actually difficult to find pharmacies that will compound that for us. So again, the liquid is the mainstay, and the dose that we use in our protocol is 0.2 milligrams per kilogram every 8 hours. I certainly have a lot of families who are trying to, they're trying to catheterize their child 3 or 4 or 5 times a day. They're trying to remember to give medications. And if that's difficult, I certainly will change the ditropan dose to twice a day. to try to facilitate facilitate ease in helping the families to have a schedule that they can maintain for their child. So oxybutynin or ditropion is approved by our FDA. It is definitely efficacious, probably more so than a lot of other anticholinergics. However, there are certainly side effects that go along with it. The long-acting formulation, so ditropion XL, it improves patient compliance because they only have to take it once a day. It also decreases the side effects, but it's not available in a liquid form. So until patients can take this medication by capsule, they're kind of stuck with the short-acting ditropion. Again, the intravesical has fewer side effects because you avoid the first-pass metabolism through the liver. But there are no randomized controlled studies in the pediatric population. We do use it, however, particularly in older children. There are transdermal patches and gels. They're very expensive, at least in the United States. They're also difficult to consistently get. Sometimes you can write a prescription for them and patients can go to a pharmacy and get them. Other times, it's nearly impossible to find them. In the patients that I've cared for where we've tried this, there's a lot of skin irritation and there's a lot of problems getting the patch to stick. So families get very frustrated if they pay a lot of money for these patches and then they don't stay on. And again, it's just, there's not a lot of access and it's not covered by insurance. So families have a difficult time. So more selective anticholinergics, so tolterodine or Detrol, has been shown to have reduced side effects, but in general, the selective anticholinergics have not been studied in children. However, Detrol has. It's actually the only other anticholinergic to have undergone randomized controlled trial in children. It's another medication that we will use, but again, there is not a liquid formulation. So this is something that kids cannot take effectively, especially because it's long acting. So you cannot open or crush the capsule. You can't take this until they're able to swallow a capsule or a pill. This is the study where there was 42 patients enrolled in a 3-month study and all age groups reported improvement in leakage. So this is a medication that I'm going to talk a little bit more about. It's mirabegron. And this is a beta-3 agonist, so it's a different type of medication. We've actually seen a lot of improvement. One of the initial studies was a study with 66 children. The average age was 11. Half of them got mirabegron plus an antimuscarinic, and half just got mirabegron alone. They were all treated for 6 weeks, and they had a median duration of 10-month follow-up before they repeated urodynamics. And what it showed is that there was an increase in bladder compliance, bladder capacity, and reduced incontinence episodes. So this is a medication that really has been very successful for patients. It has fewer side effects, constipation in 4.5%, headache in 3%, and high blood pressure in 1.5%. The blood pressure thing is actually more prevalent in adults. And so certainly if you have a child, a teenager, or a young adult that's on this medication and they have borderline high blood pressure, this is something that has to be followed. But again, there was another more recent study that was actually just published within the last year where they looked at patients age 3 to 18. So they were testing younger patients. And again, they saw a significant increase in the maximum bladder capacity, as well as bladder compliance, volume until the first detrusor contraction on urodynamics. They also saw an increase in the amount of volume that patients were catheterized for because they were leaking less. They also saw a decrease in detrusor pressure and the number of leakage episodes that patients were experiencing per day. This is a medication that is very well tolerated and was well tolerated in this study. And so it's been found to be safe and effective in children with neurogenic bladder. It improves all the important urodynamic parameters, which is incredibly important for protecting the upper tracts, which is the most important thing. It comes in 25 and 50 milligram tablets, which must be swallowed whole. But actually, just within the last year, the suspension was approved. So again, this has been very, very good for children here. But it is an expensive medication, and in the United States, if we prescribe a medication that's more expensive than other medications, we have to do something called a prior authorization, which just means we have to sort of talk to someone at an insurance company and explain why we're doing this. And we do this so frequently for this medication that we actually have kind of a form letter because we have a lot of patients taking this, and hopefully it becomes more widely available because it really is. It improves, it helps protect the kidneys because it helps the bladder be better controlled. Sort of another class of medications, and this is kind of the theme. We all like to do surgery, but the vast majority of these patients can be managed and should be managed medically, and surgery kind of reserved for the patients that fail medical management. So alpha blockers are aimed at decreasing the tension on the urethral sphincter and thereby decreasing the leak point pressure. So this was a study looking at 14 children who were aged 6 to 16 who had neurogenic bladder and actually had leak point pressures that were in the danger zone, that were over 40 centimeters of water. They were given doxazocin for 6 to 8 weeks, and they noticed differences in both the leak point pressure before and after treatment, but they were not statistically significant. And so this was found to not really have any efficacy in children with a neurogenic bladder. Now, where this medication is actually helpful is children that are actually able to spontaneously void. This is something that, and we'll talk a little bit about a little bit more later, but in children who can void a little bit spontaneously, this is a medication that can really sort of help them empty better and perhaps even be continent. Another alpha blocker, a more selective tamsulosin. This was a larger study. 161 pediatric patients participated in a double-blind randomized trial. Again, they all had a leak point pressure of greater than 40, so in the danger zone. And there was a wider age range, 2 to 16 years of age. 51 patients, so over a third actually responded. So their leak point pressures were reduced below 40. However, there was no statistically significant difference in response rates between the tamsulosin and the placebo group. There was no change in hydronephrosis or the post-void residual. This was another study looking at another selective alpha blocker, and this was, again, a multi-center, very well-designed study looking at patients with hydronephrosis. And at the end of this particular study, similar to the one with tamsulosin, the proportion of patients that responded with their leak point pressure was not significant. However, there was a 40% response rate in the affected kidneys. So the hydronephrosis, the dilation improved. And this, I know because one of the people that participated in this study I work with, and even though this was technically a null study, so it wasn't significant, the pediatric urologists that participated in this study all will use this medication because they feel like it worked. It just wasn't statistically significant. So this is something that we use in our practice, but again, it's an off-label use, and it certainly can be expensive for families. Botox is another medical therapy or procedure-based, but avoids big surgery that we use a lot in our practice. This is a study, 17 patients aged 6 to 17 years of age. And what they did is they looked at incontinence episodes and how long the results lasted. they got urodynamics before the Botox injection and 1 to 3 months after. And this has been repeated in multiple studies, but it shows that the episodes of incontinence significantly decreases, so that's good, reduces the maximum detrusor pressure, also very good, and increases bladder capacity. So these are all very important things. However, in all of the studies with Botox, what's important to know is that patients that have very poor bladder compliance, they do not respond to Botox. And so these are the patients that are the most at risk for upper tract damage, and the medication doesn't work. And so the Botox injection doesn't tend to work. So it's important to keep that in mind. This is another study looking at Botox, a larger study, again, looking at the leakage between catheterization, and I think arguably more important, what are the urodynamic parameters show, what's happening. And again, this study showed the same thing, that the bladder capacity increased, and compliance got better, but not in the groups that started with very poor compliance. So again, Botox can be a very good tool, but for the patients that need help the most, it just doesn't work. And also, Botox injections often have to be repeated every 6 to 12 months. And so that's not necessarily something that families or patients want to do long-term. As much as we all care about the bladder, we cannot overestimate the importance of the bowel. So, you cannot successfully manage a neurogenic bladder if you're not also addressing the bowel. And just like with the bladder, you have to kind of look at what a child's physical status is, what their social situation is, and what their developmental needs are. If a child doesn't have a lot of cognition and doesn't have a lot of manual dexterity, then trying to do colon enemas, if they can't even sit on a toilet, that may not be what's best for them. They may just need softeners and laxatives to sort of have bowel movements into a diaper. The most sort of benign thing is to start with dietary modifications. So to make sure that kids have a varied diet and even do fiber supplementation. Most often in kids with spina bifida and neurogenic bladder, we have to do more than just that. We do talk to families about making sure that their children have adequate fluid intake. In the United States, certainly kids a lot of times do not drink water. They drink a lot of milk. They drink a lot of juice. They might even drink soda. But it's really important to stress water intake. And so these are the numbers that we give parents to try to help them hit these targets, not only for overall health, but also to help kind of them have softer bowel movements. And then there's laxatives, softeners, suppositories, the whole gamut of things that we can get to help kids have softer bowel movements. One of the things that we see is that some of these children, especially if they're higher functioning, they are continent of their stool because they are constipated. So they will have very hard bowel movements if they apply manual pressure, but they don't mind that because then they don't have stool accidents at school. And so it's important to know that if there's a child that's kind of functioning like that, if you give them a laxative, they're going to have stool accidents and they're actually going to be very unhappy with that change. And so one of the things that's become very, very prevalent in our practice has been to do transanal irrigation. And the system that we have to do that is called Peristeen. And what it is it's just retrograde injection of water into the colon through this rectal catheter. There's a picture of it there with an inflatable balloon. And so what happens is these patients you will instill water and then the balloon gets deflated and removed, and then the water and all of the stool volume flushes out. This is one of the first, or more recent, but also one of the first kind of big studies looking at this and in kids. And this is 109 patients who are, pretty young, average age of 7 years. And they only had to do these irrigations 2 to 3 times a week. So this is something that families do not have to do every day. The dose or the volume of irrigation was 5 cc's of just tap water per kilogram. And they followed them for 4 years, and over 90%. So most of them achieved fecal continence. And so this is actually something that's been very positively received in patients. But it, like so many of the things that I'm talking about, can be cost prohibitive. This is just a picture, and I'm going to talk about what we do about that in just a second. This is just another illustration of how this works, where you put this rectal catheter in, inflate the balloon, instill all of the water up the descending colon, and then remove the balloon so that the stool and fluid can be evacuated out. So, like I mentioned, there's this fancy rectal catheter and pump and all of this stuff. And you can actually do the exact same thing with a 30 cc Foley catheter. And so if you use a 30 cc balloon catheter, it goes in the rectum, you inflate the balloon, and then you can use just a catheter tip syringe to instill the same volume of tap water. It actually does the same thing. I think one of the things about what this does is it's a time consuming process. It might take a family, 60 minutes to do this, but if they can do this twice a week and their child doesn't have stool accidents and they're fecally continent between these irrigations, it can be it can really be life-changing for them. One of the things I think that's important to know, and I had a 14-year-old girl, she was actually the one that told me this and taught me this, is she said, I can use my hand. She can cath herself through she has an appendicovesicostomy. And she said, I can cath myself through my belly button. But she said, I don't have the balance to stand and put this catheter in by myself. And so I think it's important too, when we talk to families about these things, it depends on a patient's age and what their ultimate goal is. Because if they want to be independent, but they can't do these irrigations by themselves, then we sometimes have to move on to surgery so that they can do their enemas by themselves as well. This is another one of the topics that's sort of near and dear to my heart, and it's sort of nutrition and weight in these patients. I think what happens, at least I know in our clinic, is some of these patients with neurogenic bladder are heavy. So their weights and their BMIs are heavy, but they're actually very malnourished. Their albumin and protein levels are quite low. And we know that malnutrition can lead to worsening of chronic diseases and also make patients more susceptible to infection and delayed wound healing. And so, it's certainly important to address the nutritional status in these kids to help prevent any sort of morbidity, but certainly before surgery. And so when I have a patient who's going to get a bladder augmentation or an appendicovesicostomy, we will sort of talk with the families, because that's usually something that we know well in advance. We'll talk to the families and get nutrition labs and try to sort of optimize their nutrition before we do the surgery to sort of help with wound healing and just help them in general. And we're fortunate, we have a clinic where we have a neurologist and urology, orthopedic surgery, and we have a dietitian in that clinic, and she's incredibly helpful with these patients and helping them to try to maintain good nutrition. Another issue with neurogenic bladder is kidney stones. 5 to 11% of all patients who catheterize will ultimately have a kidney stone. They tend to have more stones and it's harder to treat them. They tend to have longer operative times compared to children that do not have neurogenic bladder. Not surprisingly, patients with neurogenic bladder will also have a higher complication rate, 25% versus 17%. And it's also harder to get all of the stones. So they have lower stone clearance rates. A predominance of infection-related complications, not surprisingly, because these patients tend to be colonized from being intermittently cathed. And so it's important to check a urine culture before doing any kind of stone surgery so that we can treat any bacteria that may be present to try to limit their postoperative complications. This is just a picture of a nephrectomy that I had done. It's been several years ago now, but in a young woman with neurogenic bladder who was seen and had a couple of small stones. No one thought a whole lot of it. She was sort of lost to follow up, and then that stone very quickly progressed to a staghorn, just kind of filling up the entire kidney. And she, over the course of a couple of years, lost function in that kidney. It had about 10% function, so she ended up getting a nephrectomy. And obviously this is something that with closer follow-up, we potentially could have prevented. So I always remember her when I follow my patients with stones. I think, this is something, one of the tenets of managing patients with neurogenic bladder, and it's that a hostile bladder leads to kidney damage. And so one of the sayings that I was taught is that the bladder is to the kidneys as a muffler is to the engine. So if the muffler's not breathing easily, you burn out the engine. And so we just have to take care of the lower urinary tract to protect the kidneys. This is an image of a patient with neurogenic bladder, actually spinal cord injury, not spina bifida, who, had two essentially normal kidneys and then came in, found to have pyelonephritis, so a bad kidney infection. You can see the striations on the CT scan, but a blown out kidney. And that was just a pop off from all the pressure in the bladder that was poorly managed. And so I can't stress this enough, that caregivers and parents are really the keys to success. And it's important for parents to sort of understand why we care about the bladder. We care about the bladder because we really, really want to protect the kidneys. And one of the reasons why we start patients on intermittent cath when they're born is so that the parents know how to do it. Because even if they don't need to be catheterized when they're 3 months old, they very likely will when they're 3 years old or 13 years old. And so sort of having that become part of the family's life makes it easier in the long run. And, one of the things that I put in here was communication with access to healthcare records. And one of the most amazing things that I've seen when I've gone to other countries to participate in cases is that, whether it's El Salvador or Mongolia or Palestine, families come with a pristinely cared for record and a folder, and they hand it to us. And that's incredibly helpful. In the United States, we have these electronic medical records and patients have access to it, but one hospital doesn't talk to another hospital, and it can be very difficult if patients get care at different places. And so, just in empowering families to have their own healthcare records, I think is really, really helpful, and something we need to do better at. We need to be better about that in the United States. As I mentioned, medical management is the first and second and third line of treatment for these patients. And all of these patients should really go through the non-surgical interventions before any major reconstructive surgery. But certainly there are patients that need surgery. Appendicovesicectomy is one of the more common reconstructive surgeries that we do for patients with neurogenic bladder. This is a patient, this is actually a patient that has a history of posterior urethral valves, not spina bifida. And my partner always laughs at me because when I do an appendicovesicectomy, I fortunately very often find a long appendix, and he claims that his patients all have short appendixes, but this patient had a beautiful 13-centimeter appendix that I brought up to his belly button. This is a patient with spina bifida who had an appendectomy for appendicitis. So she got a Monty tube. We used a small segment of her ileum to create her catheterizable channel. She also has a sacostomy tube here, which I'll talk about a little bit. And this is a patient with bladder exstrophy who ultimately had a sigmoid pouch. We removed his bladder exstrophy closure had dehisced and failed a couple of times, so his bladder was removed, and we created a sigmoid pouch, reimplanted the ureters down here into the sigmoid pouch, and then gave him an appendicovesicostomy there. So he essentially had like an Indiana pouch to manage his urine. And so I tend to, I will sometimes do my appendicovesicostomies through a fan and steel incision, other times through a midline, depending on what else I'm doing. If I'm also doing an augment, I like to do a midline incision. If it's a thin patient and I'm just doing an appendicovesicostomy, I will do a fan and steel incision. But I tend to bring the appendix to the belly button if I can. And there's a picture of that there. This is the patient I mentioned who had her appendix removed. And so she also had a Chait sacostomy tube. So this is something that if the appendix isn't long enough to create both a catheterizable channel for urine and a MACE channel for stool flushes, we can put this little device in, and there's this little trap door here, and we can open it, and then there's a little connector piece, and they can do flushes. So the transanal flushes go from below. This is where this patient, I just saw her in clinic this week. She puts 300 cc's of water in through this tube. She does it every other night. And it cleans her bowels out, and she doesn't have any stool accidents in between. This tube does have to be exchanged every year though. But this tube, once it's in place, can be exchanged in clinic if patients will let you do that. But again, you have to have sort of access to this tube. It's just another alternative if you don't have an appendix for a MACE, excuse me. If you have a young child with a really hostile bladder and it's not responsive to intermittent catheterization, or parents can't for whatever reason catheterize, and some families just can't or won't, and that's okay. It's just important to know that. We'll do vesicostomies. This is the picture of a vesicostomy that's clearly it's clearly healed. You can see and you can actually see that. I like this picture because you can see a drop of urine coming down. And so I will do vesicostomies for these children, particularly if they're young. An ileovesicostomy, so taking a small loop of ileum and hooking it up to the bladder and then bringing it as a stoma to the abdominal wall. That's something that it's incontinent because they'll just drain into a bag or into a diaper, but that's something that works to drain the bladder well and protect the kidneys, particularly in patients whose social continence is not as important. And then for the patients that want to be or desire to be dry and continent, a Mitrophanoff where they can catheterize with or without a bladder augment are the options. And whether or not to do a bladder outlet procedure, this is something that's kind of hotly debated in pediatric urology, whether or not to do a sling, whether or not to reconstruct the bladder neck. They may actually be needed to keep patients dry, but that should never, ever be done at the expense of the kidneys. And so it depends, again, on what the parameters of the bladder are and also what the family is able to do. So just a quick little bit about the appendicovesicostomy. It's one of my favorite surgeries. The appendix has a reliable blood supply. It's the appendiceal artery, which is a branch of the ileocolic, which is comes off the SMA. If the appendix isn't long enough, you can always incorporate a segment of the cecum, just tubularize the cecum. Excuse me. It is a very durable channel and tends to have fewer late complications than some of the other reconstructions. It's very, very durable and a very nice procedure for families. When we do an augment, the question is whether you use small or large bowel. We tend to use the ileum a lot. It's the most compliant and tends to have less mucus. The patients that have a lot of mucus tend to get more urinary tract infections and also form a lot more stones. They can also have a hard time emptying their bladder if the mucus clogs their catheters. So I will take a 25 centimeter segment that's got a good vascular arcade and that can reach the pelvis without any difficulties. And we avoid the terminal 20 centimeters or so because we want to retain bowel salt absorption and vitamin B absorption. So it's important obviously to find those landmarks when we do the augment. When we take the colon, the biggest thing is it tends to have a lot more mucus. And so these patients have to irrigate their bladders more. People can irrigate with normal saline, with bottles of saline, but they can also irrigate with tap water. It's completely fine. The nice thing about the sigmoid is that there's good muscular backing. So if you're having to do a reimplant, you can reimplant easier into the sigmoid than you can into the ileum. Because of the bigger diameter, you can take a shorter segment. I'll usually take about 15 centimeters. And the sigmoid, especially in patients with spina bifida that have neurogenic bowel, they tend to have this very enlarged kind of floppy sigmoid that just kind of wants to go right on the bladder. So it makes it technically easier. The right colon is based on blood supply from the ileocolic, and the sigmoid derives its blood supply from the IMA. And finally, just a little bit about the MACE, so the anterior grade colonic enema. So it's a continent channel to the colon. And so you basically just leave the appendix obviously attached to the colon. We will put some sort of sutures around it so that it doesn't leak. So just kind of purse string around it so that you can put a catheter through, but just sort of to provide an anti-reflux mechanism so stool can't go out. And then we bring the appendix either to the umbilicus if they don't have their urine channel there, or to the right lower quadrant. Fecal continence with this is very high. It's greater than 90%. And what's nice about this, what's not nice is obvious, it's a surgery to do it. But what is nice about this is kids that have good manual dexterity, they can usually put catheters in their abdomen without any difficulty. It can be difficult for kids if they don't have perfect balance and lower extremity strength. It can be hard for them to put a rectal catheter in. But I have a lot of patients who can do these enemas all by themselves, which as they enter adulthood becomes very important for them to be independent. And so my take-home points are that anticholinergic, so ditropan and intermittent catheterization is the mainstay of treatment. As much as we like to do the surgeries, most of these kids can be managed medically. If you've got patients that actually can void spontaneously, alpha blockers sometimes can really help. And the non-selective alpha blockers work just as well as some of the more expensive selective alpha blockers. I do give those, I have kids take those kind of at bedtime just in case it impacts blood pressure. Botox increases capacity, improves incontinence, but it doesn't help in the patients that need the most help, which is those with a poorly compliant bladder. In all of these kids, if you want to successfully manage their bladder, you also have to address their neurogenic bowels. That's important. And then finally, perhaps the most important is that protection of the upper tracts trumps everything else. So protecting the kidneys is key. And I just want to say thank you. This is the last trip I did because of COVID. It's been 2.5 years now, but this was the group in Mongolia. And I just want to say thank you to Ashley and to everyone at IVUmed and to everyone for letting me give a talk today.
Thank you, Dr. Arlen. That was wonderful.
If anyone has any questions, I'm happy to take them.
Thank you very much for that good presentation. We have learned a lot. I just want to inquire, how often do you augment the spinal bifida patients? And which circumstances do you augment?
I would say that I've been at Yale for 5 years and I've done about 1 augment a year. So it's certainly not particularly common, but I tend to augment in kids that have failed medical management. And so they have, a small capacity, high pressure bladder, then I will augment them if the parents have demonstrated that they will consistently catheterize. So as long as the parents, because once they're augmented, the catheterization is so important. And so if they've got a small capacity, high pressure bladder that doesn't respond to meds, then I do an augment. And it's probably about 5% of our spina bifida patients that ultimately, 5 to 10% that ultimately need an augment.
And finally, when you do the vesicectomy, do you always close off the bladder neck, or you?
I do not. I leave it open.
You do not.
Mm-hmm. I will do a fascial sling or bladder neck reconstruction, but I do not close the bladder neck.
Thank you.
Thank you.
Go ahead, Dr. Kingago.
Yes, thank you very much, Dr. Angela, for the presentation. One of my questions I didn't get clearly, the patients who do not have DSD and their leg point pressures are below 40, what was the prognostic value again? Are those the ones who are more likely to void spontaneously or not to require catheterization?
They won't necessarily void spontaneously, but if they're young and they just leak at low pressures, they can safely leak into a diaper. And those are the kids that maybe don't have to be catheterized consistently until they're a little older. It's better for their kidneys, but it doesn't necessarily mean that they'll be able to potty train normally. It just means that it's safe for them to leak into a diaper.
Okay. What about prophylactic antibiotics? Do you use them routinely?
I use prophylactic antibiotics in the patients that have reflux, at least in the first few months of life. And we also use prophylactic antibiotics when families are first learning to do the intermittent cath. But once families feel comfortable doing clean intermittent catheterization, if kids do not have reflux, we do not leave them on it long term. We have a hard time getting families do not want to give antibiotics every day anymore.
Okay. My last question, for the Botox injections, do you avoid the trigone for fear of reflux, or you give systematic irigo?
We include the trigone and then lateral and posterior walls. We do inject the trigone.
Okay, that's all. Those are my questions.
Thank you.
Well, if there are no other questions, we're so thankful for your time, Dr. Arlen, and to Doctors Kinganga, Kitesa, and Kyria, if you're here, thank you for helping coordinate.
Thank you so much. Thank
There
you.
is a question in the chat real quick. Any
Okay.
comment on
Thank
bladder
you.
training and fluid schedules you employ?
Oh, sorry, I didn't. Sorry, could you repeat that?
Any comment on bladder training and fluid schedules you employ?
You know, we do encourage a lot of, you know, like water intake more to address the constipation. But, you know, as far as like whether or not a child, if they have, say, tethered cord, so a more mild spina bifida, I tell parents, you know, when a child is 3, if they can sit on the potty every 2 hours and try to get them to go. But a lot of these kids really cannot volitionally void. Some of the tethered cord kids can, very, very few spina bifida kids can. But I will, if it's a tethered cord patient at about age 3, I will talk to the parents about trying that.
One other question, what is the reason for reversing the appendix as a channel?
I'm sorry, for reversing?
What is the reason for reversing the appendix as a channel?
You mean reversing? I guess I'm not sure. I like whether I don't know if the question is maybe what, you know, which end of the appendix you bring to the skin versus to the bladder. And if that's the case, I actually, whichever way the appendix wants to go is the way that I will put it. So sometimes the colon or the proximal end of the appendix ends up at the bladder. Sometimes it ends up at the skin. And for me, it's just how the appendix with its blood supply wants to lay.
The books insist on reversing. I was not sure why the sickle end comes to skin. So there's no real reason. You can do it either way.
And if you can do it either way. And however that appendix wants to lay is how I put it.
But if you have to implant, it's much easier to implant the distal stuff, this end. And also even catheterization is much easier.
And
I think there's reason for reverse.
Yeah, I'm someone who, you know, with every stitch that I put in with these, I replace the catheter to make sure it goes easily. I agree.
All right. Well, again, thank you, Dr. Arlen, and thank you everyone for attending.
Thank you. I hope everyone has a good day.